The following podcast is part of a certified educational activity titled Improving Outcomes for Patients with Nontuberculous Mycobacterial Lung Disease, Navigating the Complexities of Diagnosis and Management. Access the entire activity and complete the post-test at peerview.com/GRG860. Downloadable infographics are also available.
This is Kevin Winthrop. I'm a professor of infectious diseases and public health here at the Oregon Health Science University. And I'm today talking to you about improving outcomes for patients with non-tuberculous mycobacterial lung disease, or NTM lung disease, navigating the complexities of both diagnosis and management. NTM are organisms that come from the environment. In the world of Mycobacterium, there's really three worlds. There's Mycobacterium tuberculosis, there's Mycobacterium leprae, which causes leprosy, and then there are all the other Mycobacterium, or the non-tuberculous Mycobacterium. They are environmental organisms. They come from soils, lakes, rivers. They're ubiquitous in municipal water supply systems all over the world. They survive chlorination. They like biofilm. They live with amoeba, legionella, other gram-negatives, and they really are very good at forming biofilm and living in the biofilm. Not all of these species cause disease. In fact, there's nearly 200 NTM species now that have been identified. And I'd say only a handful, probably 8 to 10 of them, are common to cause disease. In the world of Mycobacterium, we roughly split these up into slow growers and rapid growers. The most common slow growers causing disease around the world is really Mycobacterium avium complex and the organisms associated with that complex. The most common being Mycobacterium avium and then Mycobacterium intracellulare. Both of these cause the overwhelming bulk of pulmonary disease and even the majority of extrapulmonary NTM disease in the world. About 3/4 of NTM disease overall is pulmonary. And again, MAC is the most common. In the US, we also see Mycobacterium kansasii, and then much more rarely Mycobacterium xenopi. Probably the second most common cause of pulmonary NTM disease in the US is Mycobacterium abscessus. But to give you a flavor for things, MAC causes probably 85 to 90% of all pulmonary NTM in North America, with the rest being caused by abscessus. Kansasii primarily in the southern parts of the United States, and then a little bit caused by xenopi, which you tend to see in the northern border with Canada, particularly in the upper Midwest. In terms of the important rapid growers, I mentioned Mycobacterium abscessus with regards to pulmonary disease. We also see rapid growers in the extrapulmonary setting. Even though MAC is the most common extrapulmonary NTM, you much more frequently see rapid growers as compared to other slow growers in that setting. In terms of incidence and prevalence of NTM lung disease, all of these studies have shown an increased incidence the last 10 to 15 years of pulmonary NTM. And again, MAC is most common. Mycobacterium abscessus is probably second most common, along with Kansasii. Data in terms of incidence actually was very hard to come by until lately. Most of these studies have looked at prevalence. We were the first study that I'm aware of to identify NTM lung disease incidence, and we did this in Oregon in a population-based study where we had complete access to all NTM lab reports for a 7-year time period, and we were able to calculate incidence. And that incidence was 5.6 per 100,000. That was the incidence of new cases occurring annually. And I think this is probably fairly generalizable to the rest of the United States. Most of our patients are females, and so this is thought to be a disease which disproportionately affects females. Before age 60, of course, disease is much less common, but does tend to be more common in males. But after age 60 and every decile of age after that, you see more and more this is a female disease. A couple reasons for that. I think obviously females outlive male counterparts. And it also may be that some of the underlying diseases that predispose to NTM, such as bronchiectasis primarily, are more common in females. So there's really two main types of disease, and I divide these up kind of in the older male smoker COPD type disease. And really, this is the emphysematous form of disease. It's more common in men, but certainly occurs in women, and it's really associated with smoking. And then there's the other form of disease, which tends to be more common in females, and it's the quote unquote Lady Windermere phenomenon. So with regards to the former, the emphysematous form of disease was really first described in males in a veterans home several decades ago. And it was really thought that pulmonary MAC caused cavitary disease primarily in smokers and in men. And this was its original description. It does tend to be more rapidly progressive because, again, the lung is emphysematous. MAC can eat through that type of lung much more quickly. And that is what we tend to see, more of a consumptive or TB-like picture, but not always. Now, the Lady Windermere form of disease was called this because of a Oscar Wilde character of a tall, thin woman, tall, thin individuals, often with a pectus deformity, often with scoliosis. And we usually see this disease start in the right middle lobe or the lingula, and it's characterized by nodular interstitial infiltrate, and really it's heavily associated with bronchiectasis. Risk factors for NTM lung disease, I've mentioned several already. In terms of the risk factors for actually getting the disease, if you're exposed to NTM, most of these have to do with underlying lung architectural abnormalities. So bronchiectasis or dilatation of the airways, that chronic inflammatory airway disease, those individuals are at high risk for acquiring NTM. Now, of course, NTM can cause bronchiectasis as well, and we see that go both ways. Patients with cystic fibrosis who develop bronchiectasis, of course, and other conditions like alpha-1 antitrypsin also associated with bronchiectasis. Emphysema, I mentioned. Prior infections like TB, this is certainly a well-documented risk factor for NTM of the lung, and it's because TB causes bronchiectasis and it sets someone up for later acquiring NTM from the environment. GERD with microaspiration, it's often the great debate at some of our conferences. Some of these individuals have reflux and aspiration is a route for NTM that have been ingested and they're in the stomach to reach the lung. I think there's no doubt that some patients do have this as an important cause of their disease. In terms of diagnosis, who should you suspect? Well, certainly older individuals, older women primarily, but even older men, they have a smoking or emphysema history. Certainly that's a risk factor. If they have underlying bronchiectasis, certainly you should suspect NTM in any of those types of patients that have persistent cough or chronic cough or fatigue. Often it's the cough or the fatigue that are the driving symptoms of this disease or drive people to seek evaluation. Some people develop constitutional symptoms, particularly if they have cavitary disease, of course, and these include weight loss, fatigue, malaise, fever chills, and night sweats. Those are less common, but we certainly see those in individuals who have higher burdens of disease or more progressive disease. Most patients take months and sometimes years to be diagnosed because there's lots of other conditions that cause chronic cough, asthma, GERD, ACE inhibitor use, etc. So there's a number of things that patients are considered for usually before they get to a CT scan or before they get to NTM as a consideration for a diagnosis. What are the diagnostic criteria? Well, you got to have symptoms and you got to have radiology compatible with the disease. So again, here you see nodular infiltrate or sometimes isolated nodules. You can see cavities. The important point is you see infiltrate and it doesn't look like a community-acquired pneumonia. It tends to be reticulonodular in nature. It's often not associated with lymphadenopathy, although you can see some reactive lymphadenopathy in some cases. The important part of the diagnosis is the micro. So one lower tract specimen from a bronchoscopy or two positive sputum cultures with the same species, not one, but two. And the reason we require two for sputum is that we know some patients have upper airway colonization or mouth colonization from NTM from the water they just drank that day. Or maybe they just inhaled it, but there's really no infection or colonization of the deeper airways. So we require at least two positive samples from sputum to be culture positive in order to consider someone diseased. Alternatively, someone could have a biopsy of lung tissue. If that grew NTM, then that would also satisfy the micro criteria of this case definition. So it's really three. It's the symptom criteria, radiologic criteria, and microbiologic criteria. In terms of mortality, we used to tell patients that NTM lung disease is not associated with mortality. It's really just a quality of life issue. While I think this is largely true, the 5-year mortality is higher in these individuals, and the time to death is higher in patients who have NTM lung disease as compared to similar patients who do not have NTM. So I do think it's a marker for an earlier mortality, and in most cases, it's probably not the NTM causing death. Certainly, patients with low BMI and those with cavities, particularly together, those are risk factors for progression and for earlier death due to NTM. So let's talk about treatment. We don't treat everyone with this disease. There's certainly factors influencing the decision to treat. 10% to 15% of patients diagnosed with MAC lung disease, so patients who meet the diagnostic criteria for MAC, can spontaneously convert their sputum to negative. We know that there are risk factors for progression. And when we think about treating these patients, it's a real risk benefit analysis. I know of no other infectious disease where I tend to wait for the patient to tell me they want to be treated. Most of the time, you have an infection, the doctor says they're going to treat it, and they treat it. It's a real nice example of shared decision making between patient and physician and outlining the goals of therapy and what someone might benefit or gain from therapy, and then, of course, comparing those to the potential risks of therapy. So we consider all of these things when we're discussing the pros and cons of treating these individuals. So the main benefit of treatment is it makes people feel better. Cough is usually ameliorated. Sputum production usually declines or dries up. The fatigue of this disease is also mitigated. We also tend to see the benefit on CT scans. We know that untreated MAC can be a problem for some patients. Not everyone. Like I said, some people cook along for years with really non-progressive disease. But there are case series, of course, from certain treatment centers and population-based analyses that show that some patients will progress. And again, treatment can help mitigate and arrest that progression. So once you decide upon treating, it's a shared decision-making process, and the benefits should be highlighted and the risks should be highlighted. Some of these medications can have side effects. I would say the majority of patients suffer no side effects, but a significant proportion do. And it's usually one drug. It's not all three drugs or four drugs. It's usually one that's causing a problem. And usually if you spend time and sometimes get creative, you can get around those problems. I'll also mention the importance of airway clearance. We all believe that airway clearance and hygiene is extremely important in clearing secretions, minimizing disease burden, and improving aeration in the lungs. Exercise, aerobic exercise to me is king. And, we often prescribe hypertonic saline or positive expiratory devices, sometimes chest physio or a vest, things that help patients mobilize and clear secretions. These are very important in addition to potential antibiotic therapies. So the first step in treatment is sending your isolate to a lab that's reputable for mycobacteriology and looking for macrolide and amikacin susceptibilities. The macrolide is the single most important drug. It's the cornerstone of our therapy against MAC. So it is important to verify that it works. But for the macrolide and amikacin, these are really the two drugs where we know if there's resistance, patients have worse outcomes and you're not able to use those medicines. They don't help you. So in terms of the new treatment guidelines, we will highlight this, and it is important to look for the macrolide and the amikacin. Macrolide resistance, usually the labs test for clarithromycin. You can use that as a surrogate for azithromycin as well. And for amikacin, we look at isolates that are greater than 64 micrograms per ml on the in vitro MIC as being deemed resistant. In terms of drug resistance, these are highly drug-resistant organisms. So there's really two forms of resistance. There's mutational resistance, which is what we're used to thinking about. For example, MAC isolate has a mutation in the 23SR ribosomal RNA gene. It makes it resistant to macrolides. Mutation in the 16S ribosomal RNA gene makes it resistant to amikacin. But what's harder to understand or what's harder to identify is the inducible drug resistance. And this has been a big problem in the labs for years, but it is changing now. Some of the labs are now finally telling you if your Mycobacterium abscessus isolate has inducible macrolide resistance. And this is confirmed by an gene. And this gene is present on abscessus species and abscessus bolletii species, as well as Mycobacterium fortuitum. And it's almost always functional, although 10 to 15% of times the gene is not functional. But if it is functional, like it is most of the time, even though your MIC will look favorable to a macrolide, if you incubate that organism with a macrolide for an extended period of time, you see the gene turned on and inducible macrolide resistance will come forth. So you either have to probe for the gene and shows that it's there to alert the clinician that there is inducible resistance, or you need to do a 14-day delayed incubation with a macrolide to see if there's inducible resistance. This is really important because for abscessus, without knowing whether the macrolide is useful or not is a huge problem. Those that are susceptible to macrolides will have much more favorable outcomes than those that do not. So in terms of therapy for MAC, the big difference is if you have a cavity or not. If you have cavitary disease, we add preferably at least 2 months of IV amikacin. Most of us treat intermittently, like 3 times a week, and the dose depends on the MIC shown in the susceptibility report. And this is given for 2 to 3 months, sometimes longer. It depends on the risk benefit for the patient. But it is added to the standard therapy that we use for everyone with MAC, which is a macrolide, and azithromycin is the preferred macrolide, ethambutol, and a rifamycin, and rifampin is the preferred rifamycin. If patients have cavitary disease or they're being retreated, we treat with daily therapy. If this is their first go around with treatment and they do not have a cavity, then you can start azithromycin, ethambutol, and rifampin. You can give it intermittently or daily. In terms of cavitary lung disease, I mentioned the use of amikacin. I mentioned that it tends to be more progressive, and particularly if you lose control of the cavity and it's enlarging, then surgical resection would be very important to consider. Of course, they're poorer surgical candidates if they're smoking. They're also more likely to develop macrolide resistance. Adherence to therapy, taking your medications correctly, and making sure it's a multi-drug regimen is important. You have to protect the macrolide, and again, think about using the amikacin the first 2 months if they can tolerate it. In terms of the development macrolide resistance, as I mentioned, it's a much harder disease to treat. There's much higher rates of mortality, and it's just much less likely that you're going to cure it. This is caused primarily by macrolide monotherapy, which you would think is not very common today, but it is. There's still lots of people who do it. The macrolide plus the fluoroquinolone has also been shown to confer a higher risk of macrolide resistance. And then a macrolide plus rifampin is pretty good. I mean, rifampin protects the macrolide, but it doesn't protect it as well as ethambutol. So if you're going to pick a 2-drug regimen for whatever reason, then it would be a macrolide and ethambutol. Therapies for macrolide resistant disease, then you have to get creative. I mentioned surgery as an option. Amikacin certainly is an important option, either through IV or inhaled forms. Liposomal amikacin would be the ideal option in terms of inhaled amikacin for someone who has refractory disease and particularly someone who has macrolide resistant disease. Other drugs include clofazimine or bedaquiline. Sometimes we use tedezolid or linezolid, but the MICs are rarely favorable for those drugs. After MAC lung disease, patient follow-up, you really need to do surveillance for a lifetime for recrudescent disease. I often see these patients every 6 months or even every 4 months, depending on what their symptoms are like, and then at some point maybe yearly. But occasional radiographic follow-up, X-rays, and potentially CT scans at some interval after therapy cessation are important. I often continue sputum surveillance for AFB for many years at 3 to 6 month intervals. But we know a lot of these patients, when we are done treating them, even though they're culture negative, they're often not cured or, again, have a high risk of recurrence due to environmental infection. In terms of the relapse or reinfection after completion of therapy, it's variable, but I think the Texas experience is maybe the most robust in terms of a large patient group followed, and essentially 50% of people had recurrence of a positive specimen within 3 years after stopping therapy. Reasons for treatment failure are oftentimes non-adherence to the drugs. Sometimes patients don't absorb well, so I check drug levels in individuals if they're failing therapy. Extensive disease, cavities are very tough to penetrate with inhaled or oral or IV therapies. The cavities are a protected space for the NTM, so we often can't cure them. The airway is a space. Often the damaged airway is full of biofilm, and often we can't penetrate that biofilm with anything. And MAC can hide within the biofilm. The other thing is the MAC can be intracellular and hide out from drugs by being within your own cells. So having medicines to penetrate the biofilm cavities and even intracellularly can be important. In terms of the MAC treatment algorithm, some patients don't respond to therapy and they have refractory disease. Now, this is probably just 10 or 15% of our patients, meaning after 6 months, they have not converted their culture to negative. And for these patients, it's indicated to add liposomal inhalational suspension of amikacin or ALIS. This is amikacin that has essentially been encapsulated in a liposome, and that liposome allows it to deliver drug within that biofilm of the airway I mentioned, as well as allows drug to penetrate within macrophages. And we know MAC hides out in both of these places. So this drug has the potential for improving our ability to clear MAC. And this was shown in the phase 3 trials where individuals with refractory disease either continued on their guideline-based therapy alone or they added ALIS to it. And we observed a culture conversion rate 20% higher in the ALIS group. It was 29% versus 8.9%. So this was statistically significant. It recapitulated what was seen in the phase 2 trial, and it led to the drug's approval for use in patients with refractory disease. And later, we've also reviewed and published long-term data in the patients who then finished their treatment and stopped. And there was good sustainability of negative cultures, at least in the 3 months after stopping drug, as compared to people who cleared their cultures on guideline-based therapy alone. In terms of the tolerability and side effects of ALIS, there are a significant proportion of patients who are hoarse. So dysphonia is very common. It's about 40 to 50% who start. We saw this in the phase 3 trials, and we saw it in the phase 2 trials. And most of that is temporary. Usually the dysphonia improves, particularly if you take steps like gargle salt water after using it. Sometimes we use a bronchodilator before using it. And sometimes we start intermittently and gradually increase the patient's frequency of use. Sometimes we temporarily stop for a couple weeks and the voice gets better, and then they can restart in an intermittent regimen and again gradually work up. Not all people have this problem, but if they do, there are generally ways to deal with it. Other patients have some increased hyperresponsivity in terms of the airway, so increased cough, sometimes dyspnea. Again, most of these things get better with time. There was an imbalance in tinnitus in terms of hearing complaints. We didn't see any change in audiology. There was no hearing loss associated with the drug in the phase 3 trials, but there was a slight increased risk of tinnitus with 7.6% in the ALIS group getting tinnitus compared to about 1% in the comparison group. And lastly, I'll mention there were several individuals who had hypersensitivity reactions, hypersensitivity pneumonitis, for example, and had to stop drug. So this is rare, but it's something to watch out for. So patients who have increasing dyspnea or worsening PFTs, this would be a consideration. This drug is the first drug approved specifically for pulmonary NTM. It was approved for pulmonary MAC, as I said, to be used in patients who have refractory disease or lack other drug treatment options. And it's an important part of our armamentarium now for particularly that group of patients where we had limited options to begin with. There are other drugs that we and others are interested in evaluating where many of us are using them off label. Bedaquiline would be one. There are several case series, small number of patients reported that have been treated with bedaquiline in the context of other multi-drug regimens. There seems to be some benefit. I mean, some of these patients who had not cleared their cultures for years were able to do so. But again, these are small open label studies and it really demands a randomized controlled trial. Other drugs like clofazimine, we have a FDA-funded R01, which is a blinded RCT looking at clofazimine versus placebo. There are other open observational studies, open label studies looking at clofazimine and observational case reports from institutions that show that it's well tolerated and probably associated with benefit. It has activity in abscessus and it has activity against MAC in the dish. And I think it's probably an important drug for a regimen. But again, we need more data before we can say more definitively about it. In Mycobacterial abscessus, we often use IV amikacin or IV imipenem and tigecycline. Sometimes we're using now omadacycline off label. Imipenem, I mentioned, is usually well tolerated and often the drug I start with, along with amikacin. But it really depends on the patient and the isolate and the susceptibility results. Sometimes we use other drugs, again, bedaquiline and clofazimine. Clofazimine is frequently used in these patients because it's an oral option, and usually abscessus is resistant to most, or if not all, oral drugs besides clofazimine and bedaquiline. Tedesylate, sometimes we reach for, usually MICs for tedesylate are much lower than they are for linezolid. So if you're going to use a drug from that class, I think tedesylate is probably your best bet. And again, the treatment of this entity really depends on whether or not that ERM gene is there and if it's active. If they have macrolide susceptibility, true macrolide susceptibility, then of course using a macrolide is very important in these individuals and associated with higher treatment success. Other agents, well, there's lots in the pipeline, folks. That's the good news. We just completed a phase 2 evaluation of nitric oxide. There's also a RCT out there looking at GM-CSF. There's other RCTs being planned looking at other novel compounds as well as existing compounds. It's an exciting time to be in the NTM world. I think in 10 years, hopefully I'll do this talk and it'll be much longer with all these new therapies that we can talk about for our patients. So I do see the future where we will have more options for our patients to choose from. I think we're on the cusp of a new era of new therapies that will be more successful.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GRG860. This activity is supported by an educational grant from INSMED. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.